purpose of this morning's meeting is to meet with the INMO and the Institute of Obstetricians and Gynaecologists in the first session and with the HSE in the second session in relation to the National Maternity Strategy 2016 to 2026, which was prepared by the Maternity Strategy Steering Group. On behalf of the committee, I would like to welcome to the first session Ms Mary Leahy, Vice President of the INMO, and Mary Gorman, Executive Council Member of the INMO, and Dr Peter Boylan, who is Chair of the Society of Obstetricians and Gynaecologists, and Professor Louise Kenny of the Institute of Obstetricians and Gynaecologists, who will provide us with their perspective on this key strategy document. Can I now ask Ms Mary Leahy to make her opening statement?
Thank you, Chairperson, members of the committee. The Irish Nurses and Midwives Organisation has welcomed the launch of the country's first National Maternity Strategy, creating a better future together for the period 2016 to 26. Our midwife section has particularly welcomed the recognition within the strategy of the need to give pregnant women appropriate and informed choices, supported by access to the correct level of care and support for their individual needs. Our midwife membership has welcomed the recognition within the strategy of the role of midwives in the natural childbirth experience. In particular, we welcome the recognition of midwives leading and delivering care within the multidisciplinary framework for delivering the care pathway intended for normal risk mothers and babies. In that regard, we would advise the committee that every audit of existing midwifery-led units confirm high-quality performance and high levels of satisfaction felt by mothers. My colleague Mary Gorman, to my left, here with me, has experience of such a midwifery-led unit as she works in Our Lady of Lourdes Hospital, Drogheda. Mary can further provide details with regard to the effectiveness and potential of this service model. In this regard, the publication of this strategy and, more importantly, its implementation should herald a move away from the current overly medicalised models of care in existence across the country. It has long been the view of the INMO that current maternity services underutilise the potential of the registered midwife, thus minimising the choices for the woman. It is imperative through the implementation of this strategy that our maternity services utilise the experience and autonomous practice of all healthcare professionals within the service in the interest of optimising the quality of the service and the supports to the mother and to the newborn. In that context, the organisation also fully endorses the recommendations within the strategy for the development of a community midwifery service. This development, which will see hospital midwives coming out into the community to provide ante- and postnatal care, will represent a hugely positive development for mothers and babies, bringing the service to them rather than requiring them to come into a hospital for care and support. The INMO has also noted the intention to establish a national women and infants health programme to drive forward the implementation of the strategy over the coming years. Our organisation is on record as looking forward to working with this programme to implement, in the shortest possible time frame, all of the recommendations itemised, leading to a positive transformation of this country's maternity services. However, we are aware of difficulties in recruiting key personnel to lead this programme, which has delayed the pace of progress to date. The leadership issue is pivotal and must be addressed without delay. The INMO has sought a meeting with the Department of Health for the purpose of agreeing the necessary measures, particularly with regard to workforce planning, including an analysis of training needs necessary to ensure that we have the additional midwives required to facilitate the full implementation of this strategy. This meeting has yet to take place, but we do expect it shortly. It is now almost 1 year since the strategy was published, and the INMO, notwithstanding its excellent potential and the positive response the strategy has received from all stakeholders, is becoming increasingly concerned at the slow pace of implementation. A key example of this, which goes to the heart of maternity care, is the midwife-to-birth staffing ratio, which continues to exist in this country. The accepted midwife-to-birth ratio, which arises from evidence-based practice, is 1 midwife to 29.5 births. In fairness, the strategy commits to the introduction of this ratio over a number of years as maternity services evolve through the implementation of the recommendations. However, in the short term, it has proved extremely difficult to secure the additional midwifery posts necessary to improve the current ratio, which in some units continues to be in excess of 1 midwife to 40 births, and the average being 36 births to 1 midwife across the country. The latest HSE service plan refers to the recruitment of 100 additional midwives. However, we have yet to see this happen, and in particular, there is absolutely no certainty that even advertising these posts will secure the additional midwifery expertise required in hospitals and units around the country. In addition, the strategy will require increasing the number of midwifery posts by 100 for each of the next 4 years, but again, nothing has been done to recruit or to retain midwives in our health service, despite the current shortage, and we have no sense of proactive planning. The reality is that our current services are severely understaffed. From the experience of the INMO, there is a complete absence of workforce and manpower planning as to how this critical staffing shortfall will be addressed and how will we ensure a supply into the future of midwives wishing to work in the Irish Public Health Service. This committee must understand the implementation of this strategy, which we believe everybody supports, is dependent upon an acceptance that as we remodel the pathways of care and provide choice for mothers, there will be staffing resource implications, particularly midwifery, which must be planned for, addressed and supplied. A fundamental requirement with regard to this workforce planning to realise and maintain this best practice ratio is to increase the number of direct entry undergraduate midwifery places by at least 25%, which is 125 student midwives, and in addition to expand the number of postgraduate midwifery places available across the country. The INMO believes this is self-evident, but if we are not aware of any plans to provide for this increase in supply. However, it must be noted that in recent years, a number of these postgraduate places have not been filled due to the lack of applicants. This is yet another example of the service-wide issue of recruitment and retention which must be addressed if we are to establish and maintain safe practice levels. On a more positive side, the committee should note that arising from a recommendation in the report of midwifery services in Portlaoise General Hospital, directors of midwifery have been or are being appointed to all midwifery units and hospitals, which are 19 in total. One important thing to note about these appointments is that the post of Director of Midwifery will, in the context of implementing the maternity strategy, have a remit which spans both the maternity hospital and the adjoining community services. This is most welcome and is indicative of what should happen as the strategy is implemented and will provide governance to the enhanced community midwifery services referred to earlier. We believe this strategy, which was formulated after detailed discussion and debate involving all partners in maternity care, represents a step change in our approach to pregnancy and childbirth. The recommendations place the mother and child at the centre of all services and will require all members of multidisciplinary team to alter existing approaches to facilitate new models of care totally sympathetic to the mother and to the newborn baby. Implementation of the strategy is also essential in recognition of the changing demographics with regard to the age with which women choose to have children. Maternity services will have to be capable of addressing the modern-day realities of pregnancy, including increased levels of obesity, management of other chronic illnesses and the many issues which flow from modern-day work-life balance. This requires our maternity services to be resourced, responsive and flexible, which in fairness will result from the implementation of the strategy. We wish to acknowledge the dedicated work of the steering group leading to this forward-looking strategy. The INMO, and particularly our midwife section, commits itself to working with all concerned to deliver upon the strategy's recommendations. The collective goal must be to ensure excellent standards of care in the environment chosen by the mother based upon their needs and their preferences. The recognition of the role of midwives within the proposed new pathways of care is very welcome, and our midwife members look forward to embracing this change and providing these new models of care and choices for women nationwide. Thank you.
Thank you very much, Ms Leahy. Could I now ask Dr Peter Boylan, Chair of the Institute of Obstetricians and Gynaecologists, to make his opening statement.
Thank you, Chairman, members of the committee. First of all, I'd like to say that we in the Institute would endorse fully everything that Ms Leahy has said in respect of the role of midwives and are fully supportive of what she has said. And the Institute of Obstetricians and Gynaecologists welcomes the National Maternity Strategy and hopes that it will be implemented. There are three areas which the Institute is particularly keen to see implemented without further delay. The first is that we wish to see the mastership model of governance applied nationwide, with each unit having its own separate budget and governance structure. This model has been in operation in the 3 Dublin maternity hospitals for more than 200 years. It is a tried and tested model which works. A clinician is effectively the CEO and is assisted by a Director of Midwifery and a General Manager who has the appropriate financial and clerical support. The Master is ultimately responsible for the quality and safety of the service and is therefore accountable. With that accountability goes authority to operate the service in the best interests of patients, that is, women and children. There's an identifiable person who is answerable for the quality of the service. Experience in the United Kingdom has shown that the further away from the patient the governance structure is, the more there is an emphasis on financial outcomes and less on clinical outcomes. The current governance model, whereby maternity units around the country are integrated into the general hospitals, is a failure. Recent problems in Cork and Portlaoise are good examples of this, and this failure has been demonstrated repeatedly over the past several years by well-documented tragedies. There is no budgetary protection for maternity services, including gynaecology, and so they are the first to suffer cutbacks in our hospitals. Secondly, we wish to see all units have access to expert ultrasonography services for all pregnant women. At the moment, there is a huge variation in availability of ultrasound for pregnant women around the country, and this has serious implications for the quality of care which can be given to women in pregnancy. We wish to see an increase in consultant numbers to bring us up to internationally accepted norms. It is well recognised and accepted that the number of specialist obstetrician gynaecologists in Ireland is the lowest in the developed world. There is a need for an additional 100 consultants to bring us to an acceptable level. There are other elements of the strategy which the Institute would like to see developed, such as more community-delivered antenatal care closer to women's homes. Again, learning from experience in the UK, it is essential that obstetricians and midwives work together as a team and not separately. Finally, there is no mention of gynaecological services in the National Maternity Strategy. This is a serious deficiency, and a national gynaecological strategy needs to be developed.
Thank you very much, Dr. Boland. Could I finally ask Professor Louise Kenny, Professor of Obstetrics at University College Cork, a consultant obstetrician and gynaecologist at Cork University Maternity Hospital, to make a opening statement.
Thank you. Thank you, Chairperson, and thank you to the committee for this opportunity. I too would just like to echo what my colleagues have said. We must accept the fact that the woman is at the heart of everything that we are addressing today, and not lose sight of that. Notwithstanding that, my colleagues and I at the Institute of Obstetricians and Gynaecologists welcome the National Maternity Strategy, and we sincerely hope that it will be adequately resourced and fully implemented without further delay. There are fundamental inequities in the provision of women's healthcare in Ireland in 2017. Firstly, Ireland has the lowest number of obstetricians and gynaecologists among the OECD countries, at a rate of just 3.95 per 1,000 live births. This is just over half the comparative number in the UK, for example, for the same number of births. But despite this, clinical outcomes for mothers and infants are comparable with the best internationally. We urgently need to recruit a minimum of 100 extra consultants. However, this will require remedial steps to retain our senior trainee specialists who are currently discouraged from remaining in Ireland by poor working conditions, the perception of a hostile media, and gross inequality of remuneration and contracted hours, which has been brought about by the introduction of the divisive 2012 consultant contract. Secondly, we once again reiterate the need for equal access for all women to standardised ultrasound services. At the current time, neither specialist ultrasound or fetal medicine services are available to all pregnant women in the Republic of Ireland. Even in CUMH, where I work, a tertiary referral unit where over 8,000 infants are born every year, we cannot provide second trimester fetal anomaly scanning for the majority of pregnant women attending for antenatal care. This issue remains unresolved in 2017 and exposes pregnant women attending CUMH and their healthcare providers to an unacceptable level of risk. Finally, the single most important step to safeguard the success of the National Maternity Strategy is to ensure that the governance of women's health services is robust, independent and secure. International experience demonstrates that women's health services are always the first to be cut when they are not protected by an independent governance and a ring-fence budget. Closer to home, the well-documented issues with the provision of gynaecology services in CUMH, which have led to unprecedented and dangerously long waiting times for both outpatient and surgical treatment, further illustrate this point. We believe that in keeping with the National Maternity Strategy, maternity services within the Irish hospital system need to be led by a single accountable individual with both clinical and executive authority. Thank you once again for the opportunity to be here today.
Professor, perhaps Ms Leahy or Mr Gorman might like to address the ratio of staff, nursing staff to births.
Yeah, well, I suppose I'll just give you some interesting figures. In 2014, we surveyed the number of midwives in the country, and the information was provided by the employer, and we had 1,849 midwives then, which gave a ratio of 1 midwife to 38 births, and that was based on a birth ratio of 70,879 births at that time. Now, at that time in question, we needed 554 midwives. But two things have happened since. Our birth rate has come down slightly and the strategy evolved, which actually recommends a 1 to 29.5 ratio. So we have a long way to go to get that. The issue of recruitment and retention has been mentioned. We have significant problems. In our opening statement, we mentioned that we have a problem with regarding the undergraduate programme. We have a high attrition rate from the undergraduate midwifery programme. That's the direct entry midwifery programme. Now, just for the purpose, for the committee members who may not be aware, traditionally to be educated as a midwife, you were a general nurse first, and then you went in to be a midwife. So I suppose you got a good introduction to healthcare in general. You worked in a hospital, you did midwifery placement, so you knew going in to be a midwife what was ahead of you. The direct entry midwifery is somewhat more difficult for students in that there isn't a knowledge of necessarily of what they're going into. They're going into a very high pressurised area, an area that has been under the microscope in recent years with a lot of negative reports such as the Portlaoise report. It's an area of high litigation, an area of risk, and the pressure is extreme on those students, and that's coupled with the fact that we have a deficit in midwives on the ground, so the midwives are not freed up to educate or mentor the students. So we have an attrition rate from the direct entry programme of 25%, which is absolutely extremely worrying. Now, in some pockets, we have the attrition rate as high as 40%. So there are people actually leaving a 4-year degree programme and possibly year 3, year 4, because the pressure is too much. One other problem that would be, I must highlight in that area is there is clinical placement coordinators who would be clinicians working on the ground with student midwives to educate them with regard to clinical skills, and the recommended ratio is 1 clinical placement coordinator to 15 students, and we are nowhere near that in the Irish healthcare setting. So the student midwife is not getting support, they're not being mentored, and they're finding the area quite pressurised. We have anecdotal information also that those particular direct entry students who are working in part-time jobs to support their education are actually being harvested in those areas such as retail, and that's quite worrying in that they're qualifying or coming near qualification but not practising because they're being offered salaries in retail or other non-midwifery areas that exceed that a midwife would earn, jobs with company cars, and midwives are looking at this saying, why would I take a position where I'm at risk, my licence is exposed, and I'm at risk of litigation on a daily basis in a very pressurised, stressful role when I can take something that's, far easier. We have another difficulty then with, and it was alluded to in our opening statement, with regard to the postgraduate placements. Now, we called for an increase in those placements, but we also have to acknowledge that a lot of those placements aren't being taken up by students, and there's again a number of reasons for that. One of the reasons would be that we're so short, and for the purpose of Senator Burke, there's a distinction between nursing and midwifery. They're two separate professions, but a lot of nurses who wish to move into midwifery would not be released to do midwifery education because we're short in nursing to begin with, so they're not being released. The employer won't fund the education because of budgetary constraints. Also, when a postgraduate midwife qualifies, and just for the committee's information, they've done a 4-year undergraduate nursing degree, and then the postgraduate midwifery programme would be 18 months. But the midwives that would ordinarily go into that programme have identified that when they come out of that programme, they're not getting experience, they're not being recruited. So if they're a lack of experience, they have a poor job prospect. So they're identifying, well, what's the point in doing midwifery when I won't be recruited at the end of it? And a lot of them that have come through the postgraduate system have gone back to practising in general nursing. They've actually not using their midwifery qualification. So that's an area of huge concern. So really, I suppose the answer is we have to grow our own midwives. We have to increase the number of both undergraduate and postgraduate placements. And I want to say that the midwives who do fulfil the undergraduate programme actually come out with a very high degree of education and they perform very well in the workplace. But those are the people who possibly are getting pockets of areas where they're supported and mentored, but then we'd have pockets where there's no support and no mentoring at all. So when they do come out, it works quite well. The Deputy O'Reilly, you mentioned what was needed. I think we just have to grow our own midwives, and we need to attain a critical mass of midwives in this country. You mentioned, do we need legislation to underpin that? I think we have to grow the midwifery, we have to reach a critical mass first, but I do think that legislation will be warranted further down the line, but we have an awful lot of work to do. We have great concern that we're a year into the strategy and we don't see any evidence of recruitment, or the thing that we would welcome would be the director of midwifery being rolled out in the 19 units, because heretofore a lot of units didn't have directors of midwifery, and if they did have directors, they often were directors that were nursing background, not a midwifery background. So we do welcome that, but we have an awful lot of work to do with recruiting. We can't recruit midwives from abroad for a number of reasons. They're not there. And if they are there, we have a very high standard of education in Ireland, so often there's a deficit or a difference in standard regarding the education. You mentioned also, Deputy Riley, regarding the community midwifery and the primary care. I'm a registered midwife, but I work as a public health nurse, so I'm in community and primary care. And I'm fortunate enough to be in a purpose-built primary care unit, which is world class. The problem with it is it's so busy that it's only 3 years open, and we actually find it hard to get a room within our own building because the level of turnover is massive, and that's great to see. Mm-hmm. The antenatal programmes have reached that primary care centre, so now for mums, and this is all about mums, for mums, they're having their antenatal care in a primary care centre. And then as a public health nurse, we're providing the postnatal care in the exact same centre, which is very close to their residential areas, so it's delivered in the community. So that's to be welcomed. What's to be done? Obviously, you nearly answered the question yourself. We need far more primary care centres. They need to be rolled out very quickly. Some of my colleagues will be working in single inappropriate facilities with lack of IT, lack of caretaking facilities, which aren't appropriate to bring in a clinic of antenatal women to. So if we had the infrastructure rolled out in the community, and we're talking about this for far too long, that would help a lot to bring more antenatal care into the community. We also have, and Dr. Boylan alluded to, the domino scheme. We had a domino scheme in Galway. It was taken away because of lack of funding, but we do have an early discharge programme in Galway where the midwives would take on average 4 to 5 mums who have delivered their babies home to the community within maybe 24 hours or at least 48 hours, and they would care for them in the community maybe for the first 5 days and then hand over to the public health nurse. And in that regard, I would advocate that it was a very retrograde step that midwifery was taken away as a necessity for public health nursing education, and that was a very retrograde step, because if midwifery was brought back for public health and community midwives were also coming out for the early postnatal period, that would help us to reach our critical mass. Senator Burke, sorry, I've elevated you there. Senator Burke, you mentioned about the support. I think I've answered some of that by the points I made regarding the lack of clinical coordinator for the student. So the supports aren't there for the students coming through the system, but the supports aren't there for the midwives either on the ground. Now, but the nature of midwifery practice is it's quite challenging. There's a lot of unforeseen, a lot of emergency situations, and the support isn't there. It's not there. I suppose it's underestimated or underestimated really by our management system, and also the staff aren't on the ground to actually take time to process some of the harrowing events that are being dealt with in the workplace. You mentioned about the 19 directors of midwifery and 8 weren't filled. I'm not clear on the numbers, and maybe my colleague might take that question. And there was another comment by Deputy O'Connell on why gynae wasn't included, and again my colleague Mary Gorman was a member of the strategy, so Mary might take those questions, and if I haven't answered anything, feel free to come back again. Thank you.
Mary, thank you.
Chair. I suppose, can I just add to the community midwifery services, just that there are quite a number of pockets all over the country in different places, Dublin, Cork, Galway, MLUs in Drogheda and Cavan, and there's quite good services, but in the strategy it was recognised that they were only in pockets, and it's really to get the driver to roll them out across the country in an incremental phase, okay, but we do need to get a driver, we do need to get a task force to implement and roll out community midwifery services. In regard to the directors of midwifery, yes, it's certainly very well welcomed. As previous to this, we would have had, at our highest level, would have been an assistant director of midwifery who didn't have the autonomy. We now have directors of midwifery who have the autonomy and who can lead the service. Initially, the jobs were advertised and they have been filled. However, I suppose because those positions weren't available, the bar was set high and should be set high, but they should also take into account the experience and let these people attain the qualifications along with the experience. Just on the gynae element of the maternity strategy, it was looked into, and we did, as a group, try to push that it would be part of it, but in the terms of reference, it was excluded. The Department of Health said that they would certainly look at it when the maternity strategy, that there did need to be a gynae strategy, and that should be before.
Thank you very much.
In the 20-week scan, just outside of Dublin, there's huge recruitment problems to recruit the staff to do the scans. They can be recruited within Dublin, but outside of Dublin, it's very difficult to recruit staff to do those scans. No one's interested in going outside Dublin, and I'm talking about midwifery, midwife sonographers. They're not interested.
Deputy Kelly, you mentioned about is the strategy implementable, and I suppose it is a 10-year strategy. We have grave concerns at this stage that a year has gone and there's been very little progress. I believe it is implementable, but I believe that, as Dr. Boylan said, it needs to be, the important aspects need to be identified and driven first. There must be a task force set up, I think, to drive this. It can't be a shiny strategy on a shelf, which other strategies, have ended up there. We need an annual report from each year as the years unfold to ensure, because 2-3 years can go quite easily, and then we have a crisis. I do think it can be implemented, but it's going to require a lot of dedication and a lot of investment, and we have to get the staff in place to do that. You mentioned about the budgeting. The questions were asked so long ago, Deputy Kelly, I hope I'm not answering them out of context, but just regarding budgeting, budgeting has been a problem, and the INMO have made a presentation already to the Oireachtas Health Committee, and what we've put forward is multi-annual budgets, because what's happened in the health service so far is when we're setting up any new service has to be front-loaded, and a lot of the investment goes into setting up the service without any adequate funding to drive that service forward. So we need multi-annual budgets. So a certain, I suppose, ring-fenced budget is needed for this strategy. In the current HSE service plan, there is mention of recruiting 100 midwives this year, but there's been no move to do that. So again, it needs to be driven and pushed by the politicians, if I may say that. We've had the moratorium that was out a number of years ago was the most destructive instrument that was ever waved at the health service. It was unmanaged and it was crude in that it was financially driven. So the posts were just eradicated to meet budgetary constraints. There was no cognizance given of the expertise that were being let go out of the health service. So as a result, we have pockets of deficits. There's no universal service throughout the country. One area will excel in one area will have deficits. So, the students are possibly mentored well in some areas, but to the detriment in other areas. So there's no uniform. I mentioned already that the clinical educators we've a huge deficit with the ratios there. It should be 1 to 15 for a clinical educator in the workplace, and that is not happening at all. We're possibly at double that level at the moment, so the students aren't getting the support. And I mentioned also that because we've a deficit in staff, the staff are not freed up. Now, the staff in midwifery care would be under a lot of pressure from the point of view that you have the direct entry undergraduate midwife coming into the workforce, looking for clinical skills and looking for placements. You have the postgraduate midwife. You have the general nurse who also does a certain element of maternity placement, and you have the student public health nurse coming out as well who does a maternal and child module. So there's a lot of pressure on staff to provide mentoring, and their staff just aren't there to do that. You mentioned about the strategy. Was there any evidence of any money locally given with regard to the strategy? I can speak for community. There's no evidence of that. There has been a move in where I work to bring the antenatal care into the community, but that was pre-strategy, so I can't credit the strategy with that. But my colleague Mary might be able to answer that more in depth. Community midwifery service differentials, again, I think I've sort of answered that, in that there's no kind of uniform approach, and that it's all based on resources. Deputy, if there's anything I haven't answered, feel free to say to me. Deputy Kelleher isn't here. Will I still address his?
Yes, please. Yeah.
He mentioned recruitment and retention and career pathways in particular. Career pathways is one of the major issues in recruiting and retention nurses in Ireland. The career pathways aren't there. Deputy Higgins, you mentioned about the pathway being leading to management, and I'd agree with that. We have a grade in nursing and midwifery, the advanced nurse practitioner and the advanced midwifery practitioner, and we have put forward a certain number of those, to be recruited, and we're not nearly at what we have recommended. So there really isn't a pathway, a satisfactory pathway, unless you go into management, and a lot of practitioners don't wish to take that route. The HSE will tell you later on that they are recruiting, and I will tell you that we are 350 nurses and midwives down on the end of last year. So not the end of 2016, but the end of 2015. So although there may be recruitment, there's also a huge attrition rate because staff aren't staying. So definitely the career pathway is an issue, and that needs to be developed. You asked what stage we'll be able to provide a safe maternity programme. Well, really, I suppose I have a simplistic answer to that. The resources in staffing, we have a strategy here that recommends a ratio of 1 midwife to 29.5 births. We're nowhere near that. We can't sit here and say that we have a safe practice until we reach that level. We also have a problem where staff midwives are not being released for continuing professional development or education. That's vital in any profession such as nursing and midwifery, where things are changing all of the time and one must keep abreast. So until midwives are released for education and career development, and until we reach our ratios, and until we have really good governance, which we are moving towards, and we welcome the directors of midwifery in those 19 units. You mentioned women's health and home birthing. I think that has been addressed, and Mary might wish to comment further on that. Education programmes provided for women from conception age. Really, I suppose that could improve significantly. I think that needs to be brought into the schools. A lot of women will find there's unplanned pregnancies, so at that stage, without being wished to be crude, the horse has bolted. So I think yes, there's huge room for health promotion. And health promotion has suffered hugely in the last number of years because we've become a reactive service rather than a proactive service in many areas of practice. Deputy Higgins, you also mentioned recruitment and retention, and you mentioned concerns. I think I've possibly answered, unless you want me to.
No, there was just a quick, the neonatal
oh yes, you mentioned that.
And kind of postnatal services. The thing of lactation and psychologists, and does it put pressure on the nursing services when those specialist services aren't there?
Well, I'll give you an example of what happened during the moratorium. In Galway alone, they actually, most of the neonatal intensive care, and they would have been midwives, were incentivised to retire. And once they had left, the HSE realised that that expertise was lost to retirement. And I actually had to re-recruit them as retirees, which is not ideal. And the neonatal intensive care course, Mary can correct me if I'm wrong, but I believe there's very few places on that course, and I think you may even have to go abroad to study that course. So it's something that needs to be harvested. We have an older maternal population. We have an increased incidence of early births of low birth weight babies. There are an increased number of babies going into NICU, as we call it, neonatal intensive care. So that needs to be addressed as well. But again, the moratorium, I don't wish to overly beat the HSE, but it was dreadful how they let that expertise go. It was uncontrolled and unmanaged. Lactation support, there's a huge emphasis on lactation support in the community, but in midwifery initially, but in the community from the point of view of the early discharges, the midwives that are coming out, and from the public health nurse. But unfortunately, our rates have improved, but they're still quite low. We have an initiation rate in breastfeeding of approximately about 48 to 50%, but unfortunately, we do a 3-month development assessment of all neonates and bring mums back, and it has dropped to about 38% at that rate. So really, we've looked into it, and there's lots of research on it, but our most recent anecdotal information and speaking to a lot of colleagues and midwives would be the pressure on mums to return to work and there's a cultural sea change needed there as well. We've a lot of Polish women in our communities now, and it's an automatic thing that Polish women and Eastern European women will automatically breastfeed at about 98%. And I think they're pushing our levels, our indigenous population levels are being pushed up because of the Eastern Europeans and other women that are now living amongst us.
On the choice and options about MLU care, just coming from a unit that has that care programme, the supported care pathway, just it has been recognised as being as safe as consultant-led care. There is research there which shows that there's no statistically difference between the 7 outcomes, and there's in fact less interventions. It is a care pathway that women are looking for, and it can be delivered quite easily within our current system. It is under the governance system that Dr. Boylan is referring to, so it is something that can be rolled out relatively quickly with the proper governance structures.
That is moving now that it is in the strategy?
There isn't a sense from being on the strategy. The feeling on the strategy was that it could be easily implemented within a year, even with having an alongside birth centre within the current delivery suite, but it just doesn't appear to have rolled out across the country. So maybe that's something that we could have an easy win, you know, in the interim.
Thank you very much. And finally, I would like to thank you for your time and expertise in coming into the committee on behalf of the INMO, Mary Leahy and Mary Gorman, on behalf of the Institute of Obstetricians and Gynaecologists, Dr. Boylan and Professor Kenny. Thank you very much for your time.